University Hospital from Brussels, St. Peter, in Belgium. And today I will talk about monitoring healing of orthopedic ailments of the lower limb with an original instrumented crutch. An important proportion of ailments of the lower limb benefit from biosurgical treatment. Concerning the postoperative immobilization, different protocols are prescribed by specialists. Among these, the relative mobilization with partial weight bearing is often used because it reduces the risk of musculoskeletal and general complication with a positive outcome for the patient. In functional rehabilitation of these patients, the crutch is an essential instrument which it is used in the last stage of the rehabilitation program. In the beginning of the patient training for partial weight bearing, usually a classic bedroom weight scale can be used. It is meant to help the patient to feel the appropriate ground reaction force under their affected limb and to memorize it. But it's not always easy for the patient because of the several individual factors: pain, worry, lack of proprioception, cultural and intellectual profile. A recent study shows that despite physical therapy training, the compliance towards weight bearing is deficient, which can lead to various complications. Mainly two problems appear with such a technique. First, the test is mostly based on the observation of the clinicians by looking at the patients and the weight scale. Secondly, the measurements can only be held in static mode, not in dynamics. Exact knowledge of the forces acting on the affected limb in a certain clinical situation is, however, difficult to obtain. That's why it will be interesting if we could have an instrument which monitoring the progression of functionality during rehabilitation. We can have some information for the biological progress of the healing process using the radiological exams, but the radiological outcome is not similar to the functional performances. Based on these considerations, we imagined a device that can automatically control the degree of load on the affected lower limb, the instrumented crutch. This instrument will allow monitoring of the patient gait with axial force, crutch position in a frontal plane, pitch and roll movement, and velocity of the crutch in a sagittal plane. Like that, we hope we will improve the quality of program recovery. The device is a result of collaboration between the mechanics department of University of Brussels and the rehabilitation and orthopedics department of University Hospital from Brussels, and the construction took 3 years. The device is based on the inventions patent of Professor Bertanu, automatic device from control of lower limb loading, from University of Medicine, Bucharest, Romania. But we have used also previous studies which developed similar devices. The device we imagined is a sensory device with mechatronic systems integrated and versatile, actually a smart crutch, and the logistic configuration and data analysis system that provides feedback on the degree of loading. We scrutinized the literature between 2010 and 2018, and we found 9 instrumented crutches. 2 on the market in the past, neither actually. Specific requirements in terms of ergonomics and performance have been set to achieve a correct weight bearing analysis and determine normal gait. According to European Union norms, the device is classified as non-invasive device class 1. We used an aluminum crutch, Tiplovstand, to whom we added some components listed in the table below. We needed a microcontroller and an interface. We used a gyroscope and accelerometers for measures the angles, roll and pitch, a wireless system, an off-on button, and the graphic software. It was used 4 strain gauges, configured as a Whetstone bridges, power supply for alkaline batteries, and a converter digital analog as voltage boost. This is the final result of our prototype. And how does this work? So we have 4 strain gauges that was glued on the crutch shaft, configured in the full Whetstone bridge, which measuring the compression under a crutch rod. A gyroscope and a 3-axis accelerometer calculate the angles of inclination on the X and Y axis, roll and pitch. Data is sent by Bluetooth via microcontroller, which receives and processes data to a final program developed in Python. The data are viewed simultaneously on a computer and retrieved and analyzed later. This is the crutch schema. And using our instrumented crutch, we realized a biomechanical study by which we wanted to analyze the influence of using a walking aid on the loading of the contralateral lower limb. The idea that using a single crutch diminished the loading of the contralateral limb is never proved. It's based on a theoretical assumption that by using a crutch, the moment of the crutch will help the leverage arm of the abductor's muscles to compensate the moment arm created by the body weight minus the weight of one limb. The assumption is ubiquity and often used in the post-trauma rehabilitation. Using the instrumented crutch in combination with a force platform, we dispose of an exceptional tool to validate this theoretical assumption. We've analyzed 22 participants, 70 orthopedic patients, and 5 healthy volunteers, men and women. We wanted to characterize the quality of walking and analyzing the 3 biomechanical gait parameters provided by the crutch: speed in hertz, axial forces, Newton, and position of the crutch. We recorded the biomechanical walking parameters for each patient. We choose a 2-point contact contralateral crutch gait because it is mostly prescribed at the end of the rehabilitation period of an orthopedic ailment. Before each test, the crutch was calibrated with a bed scale. The participants were asked to train for 15 minutes with the crutch, barefoot inside the laboratory on a non-slip rubber platform. Patients with neurological, cognitive, or mental disorders were excluded from the study. We combined the instrumented crutch that records biomechanical gait parameters with that of a force platform. The latter records force distribution in time and per area of the foot sole. To avoid overcounting, we decided to normalize the load for time by choosing 5 time frames at 10, 25, 40, 60, and 80%. And this is an example for the 5 time frames recorded with the force platform. These are recorded graphics obtained from the 2 instrumented, from the force plate and for the instrumented crutch, where we have registered the force, velocity, and crutch position. Our results were surprising. In 31 observations of contralateral loading of the leg opposite from the crutch with 22 subjects, we observed in 77% observation less loading on the contralateral limb, and in 22% observation we measured an increase of loading on the contralateral limb. In 29 observation of the ipsilateral loading of the leg, so the same side as the crutch, for 62% cases, we found a diminishing of loading of the ipsilateral leg, and in 38%, we found an increase in loading of the ipsilateral leg. At the final, we can affirm that our study is unique because we combined a wireless instrumented crutch with a force platform and because we compared a group of patients with various orthopedic problems with a group of healthy volunteers. The previous studies, which have been done until the moment of our study, used only the healthy volunteers. We've observed that during the study, the position of the crutch was not constant. Often, we've noticed uncomfortable use of the crutch by patients. This non-standard position of the crutch could explain why patients apply more or less load on the contralateral leg. Statistical analysis of our data revealed only a significant contribution of height and weight to ipsilateral loading, and there is no clear explanation for our results. One possible explanation could be the complete lack of proprioception of affected leg, often observed after skeletal and/or surgical trauma, and probably the absence of the damping effect of proximal muscles. In the present study, we could not corroborate a commonly used knowledge in orthopedic and rehabilitation medicine that the load of a contralateral leg from a used crutch is less, and the load of the leg near the crutch, ipsilateral, is higher. Our observation was astonishing. Not only that the variation of diminishing of the load on the contralateral leg was rather large, but in 22% of the cases, there was even more loading of the contralateral leg. The last observation is counterintuitive, but has a significant clinical relevance. First, the patients should be advised about the correct use of crutches, including specific training sessions about the use and understanding of the mechanics of walking aids. Secondly, taking into account the extremely large and unreliable variation in lower limb loading, opposite from the crutch, walking with two crutches throughout the rehabilitation phase seems safer. Walking with one crutch can be valuable to keep patients balanced after the healing of skeletal trauma or orthopedic problems of the lower limb.